To begin the webinar, we welcome from MedStar Health, Dr. Geetha Jayabalan. Dr. Jayabalan, the screen is yours.
Thank you, Pete, and good evening, everyone, and thank you for joining us for this electronic medical record webinar sponsored by the Society for Vascular Surgery. In 2021, the SVS created a new community practice section for clinicians who work in the community with a mission to establish an engaging and interactive forum for SVS members who practice primarily in a community setting. The SVS Community Practice Section, the Health Information Technology Committee, and the Wellness Committee have all collaborated to develop today's webinar about making the electronic medical record, or EMR, work for you. Our presenters today will discuss the following topics: managing the EMR to benefit your daily practice needs, making the EMR work for small independent practices, including OBL settings, and managing EMR burnout. I'm joined today by my co-moderator, President of Our Lady of the Lake Physician Group, Dr. James Craven, who will also be presenting this evening.
Thank you, Geetha. Apologize for my technology difficulties, and welcome everyone. As been mentioned, this webinar has been a collaborative effort, and we thank all of our presenters in advance for their participation tonight. We encourage attendees to add your questions to the Q&A box. We'd love to get them answered during tonight's talk. I'll be speaking a bit later about the barriers, challenges, and the advantages of using an EMR in an hospital-employed setting, also what the challenges may be in the OBL setting. But let's get started with our first presentation from Dr. Mal Sheehan. Dr. Sheehan is a vascular surgeon, professor of surgery, and medical director at LSU Health New Orleans. Mal will discuss the question of whether the EMR works for us or the other way around. He'll talk about vascular surgeons, burnout in the EMR, as well as mitigation strategies and the Society for Vascular Surgery's role to resolve these issues. Take it away, Mal.
Thanks, Jimmy. Well, you can tell from my title slide where I stand on all of this, and it's not that the EMR works for you. I have no disclosures. So a lot of what you do every day as a doctor, it comes from this document that was produced by the Institute of Medicine almost 20 years ago, in which they opined that about 100,000 people die every year from medical errors. So a lot of the checklists and the timeouts and the safety maneuvers we do are meant to prevent these 100,000 deaths a year. One of the interesting things they noted is that when patients see multiple providers in different settings, none of whom has access to complete information, becomes easier for things to go wrong. So this is kind of the calling cry for a national electronic health record. Electronic records kind of spouted from written records, right? So written records are, as we know them, only about 1 year older than me. And really, medical records before 1968 were just a collection of diagnoses and treatments, and never really, you couldn't really figure out from reading them what the doctor was doing. So Dr. Weed in 1968 published this in the New England Journal of Medicine and kind of organized our modern medical record system. So the 80s and 90s were kind of a weird time, and we started to idolize CEOs of companies. And the first celebrity CEO was this guy, Jack Welch. Jack Welch was the CEO of GE, and he led GE to a lot of profits with some kind of questionable decision-making. He laid off a lot of people to get there. But this whole thing fascinated the media, and Fortune magazine wanted to find the Jack Welch of healthcare. So they went to a reporter called Philip Longman, and what they didn't know was Mr. Longman had recently lost his wife to cancer, and Mr. Longman was a smart guy, and he realized that there really was no such thing as a Jack Welch of healthcare. So he set out to find the best healthcare system in the United States, and his findings were surprising. He found that actually by almost every metric, the VA delivered the highest quality of care in the United States, and the reason was was their electronic healthcare record system. This was the first national electronic healthcare record system. They'd actually started it in the 1970s, and the VA, being the VA, the bureaucracy initially tried to squash this thing. They didn't like it, but it became on, and by the 90s, this was their official system called Vista. And Vista provided information to doctors everywhere about the patient's care throughout their entire life. So Pete Stark was a representative from California, and in 2008, he introduced this bill. And this bill would give the entire United States a large open source health IT system. So every patient in every hospital in the country would be on the same EMR. And it would be open source, meaning it'd be free so anybody could innovate with it. But the problem is there were already a lot of EMR vendors around. And so they put all their money together and lobbied. And so instead of the what Stark's resolution would have been, we got the High Tech Act. So overnight, 260 healthcare vendors were authorized. And so this further fragmented our healthcare system. So instead of one national free EHR, we had hundreds and hundreds of them, none of which could communicate with the others. So, you know, every time I give a talk about the EHR, somebody comes up to me and says, oh, you know, the EHR really works for me. You know, it's really saved me a lot of time. And, you know, to that I say, your experience is not typical. You know, most doctors are not, you know, super pleased with it. And number two, everybody hates you. So if you think that the EHR works for you, that's great. But there's a lot of doctors for whom it does not work well. And, you know, I've gone as far as to say it is a physician health hazard. And like other public health hazards, they have the same playbook, and that's to deny that your problem is a threat to physicians. And so this is a quote that I pulled, and it's basically stating that there's not a high correlation between happiness with the EHR and happiness with your job as a physician. And it would be helpful if the media understands that and kind of publicizes that the EHR is not connected to physician well-being. And unfortunately, that quote comes from the CEO of Epic. So again, denying that this is a public health hazard is the playbook of all of these corporations, and we have to kind of fight back against that. So when I wrote to Epic for the SVS a couple of years back and said, you know, what do you have to say about this? They, I believe the term is gaslit me. And so Dr. Mast here said that, well, in fact, the Medscape survey showed that EHRs were only the 6th worst thing that doctors complain about. But the survey was flawed for many reasons. First of which, in 2020, we had a lot of other things to worry about. Namely, that was when the pandemic started. And secondly, if you looked at that same survey every other year, EHRs were at least top 3 or top 4 of things that physicians blamed on their burnout. And the survey is also flawed because if you look at what they ask, too many bureaucratic tasks, charting, paperwork, spending too many hours of work, a lot of that is tied to the EHR. So it's kind of a confusing question, but clearly the EHR is a leading cause of physician burnout, and the Medscape survey authors identified that as well. So what can we do? Well, we're going to talk about that tonight a little bit. So what I did is I wrote this letter in conjunction with some other people at the SVS, and we sent it to CMS. And what we asked for, number one, is metrics and usability standards, right? This does not exist. There's nothing the EHR has to report about how easy it is to learn or to adapt. And I think that's where we really need to start. So I'm going to let on to the other speakers tonight who are hopefully going to be more helpful to you than I am, rather than just complaining. But, you know, I do think that as doctors, we can band together because the EHR was never marketed and sold to us, right? It was sold to the hospitals, but we're their users and we have to let them know it. So, you know, I showed you the report from the National Institute of Health, and it was, you know, called "To Err is Human." But there's another Alexander Pope quote that I think applies, and that is the same ambition can destroy or save. So the EHR was a great tool, as the VA showed, but the way it is today, too fragmented and too set to do things other than what doctors need to do. So thank you. I'm going to stop screen sharing.
Thank you, Dr. Sheehan, for kind of giving us the historical perspective on where we are today. We do have a couple of questions here. One is from Dr. Molnar, and he asks, is there any chance the EMR systems would be required to interrelate, community integrate to allow portability and efficiency? government regulation is less than efficient?
I understand about 2/3 of those words. Yeah, we've done a very poor job of holding them to task, and there is Epic especially has a strong history of bucking these attempts to kind of make these things interoperable, right? I've got a fax machine in my office because my office can't communicate with the Epic system in the hospital. So, obviously follow the money where, there is no financial incentive for EHRs to integrate with each other because they don't want to be replaceable. And the other thing is that hospitals like to kind of capture patients, right? That's the whole model of the Heart and Vascular Network. The reason they like those is because it captures the patients. So if you can easily transmit your patient's information one way or another, the EHR companies don't like it and the hospitals don't really like it. So, it's again, we have to hold them to task, but so far the government has done a pretty poor job of making sure that happens.
Thanks, Dr. Sheehan. I just have a question for you as well. There was a recent article in Forbes, of all places, and the title of it was in one of these throwaway emails, but it's clearly being read by a wider audience. And the title of it was that physicians would need 27 hours a day to hit key patient metrics as derived from the EMR. And that was just the title of the article. And clearly the audience as a general population, business people, et cetera. I mean, that I think a lot of us would agree that that's probably an accurate assessment of the burden. Do you personally have any kind of concrete steps that your practice has taken to kind of decrease screen time that is in a meaningful way helpful to not feel like you are trying to be plugged into your Epic screen or whatever screen it might be 27 hours a day plus?
Yeah, well, my role here is to be the old man ranting against the system. I think I'm going to rely on the younger people to give us their tips and tricks because, I have some of my residents on. They will laugh if I attempt to portray myself as a super user here of Epic. But the point is exactly the one I'm trying to make. There is absolutely no metrics assigned to these EHRs. There's no even comparison about usability, right? So they are not graded in any way. There are metrics out there and published by physicians about this is how we could, say how usable an EHR is. But the EHR, it's laughable how much they, kind of buck these attempts to standardize how many clicks you have to do, how easy something is to do. Epic, the time thing is super interesting because now Epic records your time and they're clearly doing it as an attempt to dispute these hourly, we say now that interns, a study in New England Journal of Medicine found that interns are spending on average 10 hours a day on the EHR. So Epic did the same study and came back and said, oh no, it's only about 2 hours a day. But the way Epic tracks your time is if you're not clicking something every 5 seconds, you're not on it. So if you're not clicking something, so in other words, if you're reading something, Epic doesn't record that time as time spent on the EHR. So, again, it's a constant battle. And our hope is to enlist other bigger societies, the American Heart Association, all these physicians and nurses and CMS. But that's the only way, Epic's too big for us as a society to take them on right now.
I think that's a fabulous segue into Dr. Burgess's talk. And there's a question in the chat that I think Dr. Burgess is actually going to touch upon, which is how much bargaining power does the collective of physicians have, and SVS and similar groups, in changing the way the EHR currently exists. And I'm going to kind of pause on that question because I think Dr. Burgess and some of the other panelists may be able to get to that after his talk. Dr. Danny Burgess is the Program Director and Associate Professor of Surgery and Medicine at the University of Vermont Medical Center in Burlington, Vermont. He is an active member of the Registry Assessment of Peripheral Interventional Devices, or RAPID, as well as the Vascular Quality Initiative, VQI, serving as chairman of the Peripheral Vascular Intervention Registry. Dr. Burgess joins us to share strategies and updates on SVS discussions with Epic and PowerChart on ways to integrate vascular specific documentation requirements and streamlining data entry. Dr. Burgess, screen is yours.
Okay, thank you. Well, thanks for the opportunity to give this talk. I'll try to address maybe some of the positives that follow on from Mal's talk, certainly not all of them, but in this one particular area as it relates to the SVS VQI. And I want to thank Jim Wadzinski, who helped with a lot of this content, but I hope to be a good messenger for him and for the committee that's done a lot of this work. So hopefully many of you are probably familiar with the SVS VQI. It's 15 registries shown on the right of the slide, 18 quality groups, nearly 1,000 centers, 6,000 plus physicians, and as of last count, close to 1 million different procedures captured. And if you consider each procedure has multiple data points, we're really talking about the tens and millions of data entry points that are out there in the registry now, which certainly qualifies as big data within vascular surgery. So why is this important? Why is the EMR important for the registry and data entry? Know that the data abstraction, hospitals have different workflows, but in every place it is labor intensive. And manual data abstraction is by far the most costly component of that participation. So the hope is that integrating the registry data points into the EMRs will lead to lower cost and subsequently higher data accuracy. And if this can be realized, then ultimately will lead to increased registry participation. But there are certainly barriers to this. It's a very complex system, mapping data points from what the registry collects to what the EMRs collect. Definitions are different. Many variables are not in discrete structured data fields, but rather in free text. That's to a large extent been minimized as the registries have undergone some revisions. Certainly on the VQI side, a lot of effort is made towards standardization, but it's still an issue. So there's this lack of standardization is become because of variation in how the fields are defined. We're all very familiar that EMRs are implemented differently at each hospital. The previous talk mentioned the multiple EMR vendors. And then finally, something we have some power over is standardization of op notes. And some of my subsequent slides will cover efforts to do that. But I think the key issue here is really the lack of incentive. There's a burden for the hospital IT staff and for physicians for that matter, and a lack of incentive to implement integrated solutions. With that caveat said, I'll talk about some of the successes that have been building within the SVS VQI, and these next slides are specific to Epic integration. So early on, these efforts really were homegrown efforts at multiple different institutions that happen to have physicians who may have some expertise in computer science. They are available to Epic customers in the Forms library, but these things kind of hide on the EMR and not very visible. And to use them to date has required considerable local IT involvement for implementation. And so while this was helpful, it wasn't an ideal solution, and it did not apply across all Epic sites. So therefore the adaption was very low. So what we're working towards now is more of a global solution to define new standardized forms that can be deployed across any Epic system, and to create a globally applied API, be what's called the Epic App Orchard. And the idea is to minimize your local IT involvement to make it as easy as possible for them, so it can be close to plug as play as we can achieve, so we can overcome that barrier that we all face internally. This just shows this schematically. Phivos is the company that manages the Pathways website, which houses the data entry forms and the data. And there's a flow of data from Cerner and Epic, through Phivos, where Phivos has a data abstraction app that can collate all this and then do the quality assurance on the VQI end. There's a few places that are piloting the abstract assistant. A Cerner site, UAB, is looking at the VQI EVAR form. University of Rochester is looking at the carotid artery stent form, and Flint Vascular and the Oregon Vascular specialists are working on the PVI form with a proprietary fibrous workflow packs. Some frequently asked questions about this. The data that's entered depends on having a structured note, but this can be structured to the point that you can enter follow-up data. And the goal eventually is to have this all be automated so it flows from the EMR into the registry. The first piece that has to be tackled, though, is developing these structured notes and make sure they correlate with VQI data. The physicians and the folks on the right have done the hardcore work on this. Bob Stepaker in particular has been very helpful and is very open to hearing from everyone about their experiences and trying to make this better. So they've developed this Epic Vascular Surgery Steering Board and Success Guide, which is sort of a how-to document. Moving on to some real practical stuff, a couple examples. This is a vascular exam form that should currently be available in your Epic system as a dot phrase. So if you have not seen it before, maybe this week, type in .vas exam, and it'll bring up this comprehensive vascular exam with the checkpoints and stuff as seen there. Just one other example of some of the data that's collected within the PAD registries, including the PVI. There's the Wi-Fi scoring system, which is an attempt to grade the degree of ischemia, infection, and wound that's on a foot. It can be cumbersome to calculate, but there's this fairly easy to do system here that's integrated into the EMR for those who have interest in following that in their clinical practice, either as a clinical tool or as quality improvement or research vehicle. So those are just two examples, but this I'll turn toward the future. The as I said, the ultimate goal is to collect the data points that are relevant to the registry within the EMR, and then funnel those directly into the registry with one click, and it'll prevent duplicate entry either by physicians or third-party data abstractors, which a lot of practices employ. One question here is whether to be comprehensive or targeted in things that are collected. I think the committee has chosen to be practical and understand that it's difficult to collect everything, but if you could automate a large proportion of it, and particularly if you can automate those data points that are frequently missed and hard to dig out of the EMR, that gets us most of the way there. But certainly at least the initial pass through, the goal is not to make it 100%. In the last few seconds, I'll just mention a pet project of mine. We're running a pilot to collecting patient-reported outcomes after PVI, and we're finding that something like this can only be implemented at any large scale if the quality of life surveys we're collecting are really integrated into Epic. It's much harder to do something like this from outside the EMR system. So the hope is, as we can build these relationships and work with Epic and other vendors, that it'll open the door for some other projects to be made possible. So with that, I want to thank the informatics team, in particular Bob Stepaker. He asked me to pass on his email. He's soliciting. He would like your feedback about what's working or what's not. So try out the dot phrase, or if you have certain questions or requests about how the SVS VQI can help in your practice, do not hesitate to contact him. Thank you.
I appreciate sharing all that great information from you and your team. We'll take a minute here. Does any, and look at the Q&A to see if there's any questions that we'd like to share. I personally want to comment that I did take a snapshot, and I hope we're sharing these pitch decks with everybody. The dot phrase and the Epic, I did not know that existed in the Epic. I look forward to kind of using that with my team tomorrow, because I do think there's a lot of things. Epic works for you if you're willing to put the time in to work for it. And I do think there is an opportunity to collectively share a lot of this investment providers are putting into Epic across the SVS, and hopefully we can come away with some of those tonight. Any other questions in the Q&A for Dr. Burgess?
The one from Dr. Gaduri may be for Dr. Burgess.
Okay. How much bargaining power does the collective, as I'm getting another text here, the question is, how much bargaining power does the collective of physicians, SVS, and other similar groups have in changing the way EHRs currently exist?
That's a pretty broad
loaded
question.
one.
I think I would say for a number of years, it was very hard to get any responsiveness from Epic, but that has changed recently. They have a committee on vascular surgery committee devoted to some of these issues. I wouldn't anticipate that type of group has any broad power to steer the EMR in any real meaningful direction. I think the best we can hope for is to, in some small ways, have it work for us for a change. And there is some promise here that it can automate stuff for the VQI data entry at practices. So that would be a plus.
I think the VQI data opportunity there would be huge, just considering how widespread the Epic record really is out there, and I think it would align with probably some of the value propositions that are out there. I will tell you, from large health systems, I had an opportunity to visit Providence and Providence St. Joe's. If anybody's, it's a huge health system. They were well connected to Epic, but it's amazing, despite being as massive as some of these large health systems are, collectively, it's very difficult to kind of move Epic in a direction that works for you. In all honesty, it's just such a, it's hard to create leverage on a company such as Epic. Yeah. But I appreciate you sharing.
Yeah, one thing I would say, I'm not sure if it came through in the talk, but surgeons have to be willing to work within structured op notes. Some may or may not. That may be a barrier for some people. They're maybe quicker with the dictation or whatnot. So that's one thing that if we could be flexible to do that and use these structured op notes, that'll make it much easier for this data flow.
Good point. Any other questions? Not seeing any in the Q&A. I'm going to take this opportunity to introduce our next presenter. She is a personal friend and someone I've known for a long period of time, London Guidry. She's Chief of Vascular Surgery at the Baton Rouge General. She's also Associate Program Director for the Integrated Vascular Surgery Program at LSU in New Orleans with Mao. She specializes in open and endovascular treatment of carotid disease, open aneurysm, and endovascular repair. They have best-in-class dialysis program across the state of Louisiana, or the Gulf South for that matter. Dr. Guidry joins us to discuss how smaller independent groups can effectively use the EMR in daily practice. London, it's yours.
Thanks, Jimmy. If we can get the next slide, that'd be great. Mal is my mentor, and apple doesn't fall far from the tree. So unfortunately, I agree the EMR has been a real big kind of behemoth in pushing down doctors into the pitfalls of paperwork and what we call pajama time at home, constantly being on the EMR. So he kind of helped spearhead a paper, and I'll have to thank Dr. Amachala and Dr. Velasquez for helping write this and put it in the Vascular Specialist, about 60 papers that showed that there's really an indisputable link between EHR and burnout of physicians. And so saying that, I'm going to try to be positive. So for 7 years of training and 11 years out in private practice and 14 different hospitals, I used over 10 different EMRs. So part of that burden is learning all of these EMRs. And I will say that Epic probably is the most user-friendly once you start to use it. But again, it has a lot of pluses and minuses. If you can go to the next slide. So coming from a private practice physician who is also kind of in private-demics, does a lot of academic work as well, when you talk about being a small group, it's a huge challenge to pay for and implement an EMR. And so when you talk about how do you choose the EMR you're going to work with in your private practice, it's really actually helpful to be on that same EMR as the hospital that you work at the most. And sometimes that's not doable because that hospital is using a system that's very expensive and you can't kind of put that in the private practice that you're in. So cost is a huge challenge, not just from per doctor. You have to think about all the hardware that you have to put in, all the EHR software that you have to put in, who's going to do the implementation and assist you, who's going to train you, and then who's going to pay the ongoing network fees and maintenance. So how do you leverage all of that and try to get help? And one way you can do that is to go to your biggest hospital and say, look, I'm doing all my cases here. How can you help me in a discount that you're getting from a big system and transition that on to me? And there are programs that will help you do that, in particular EMRs. It would help you schedule your cases more efficiently. Your clinic and hospital notes can be integrated. And so trying to do that in the beginning before you spend a ton of money using 4 different EMRs is helpful. And maybe that's helpful if there are people on the chat who are about to go out into practice, who are looking to go into private practice. And then somebody talked earlier about leveraging using big groups of doctors to try to help get the hospital to, you know, if you're in a multidisciplinary group or in a bigger group of physicians, you can try to help get that assistance. You can go to the next slide. So this was supposed to be some tips and tricks. So depending on what EMR you're using, and if you're working in multiple different hospitals, like a lot of private practice docs do, I would suggest that you meet with the head of your IT department at each hospital. They actually can be super helpful. A lot of people probably don't even know who runs their IT department. Usually if you just pick up the phone and ask for IT, somehow they'll get you to the person who knows something. And the first thing is surgery and medicine are not created equal. Epic finally has started to realize that by doing subspecialty collaborations, having vascular surgeons sit on a committee and say, hey, this is not how vascular surgeons do it different than cardiologists. We weren't even in the space in Epic at all. We weren't even listed as a specific type of a doctor in the beginning. So that's one thing. Figure out how your IT people are, and then go to them, and any dot phrases you can make, any templates that you make, you can actually put them in any EMR. If you bring what you already have, even that you've made when you were a resident or a fellow, and bring that to your IT department, they can actually remake that for you. Op notes, HMPs, common notes like post-op visits, pre and post order sets, that can all be done for you. And you can also try to push those through service line meetings. If you've got a lot of private practice, vascular surgeons and different groups can come together and you can help make standardized sets, which makes your life easier. You can utilize media sections to kind of quickly upload documents from clinic if you are in 2 separate systems. But important, just try to standardize everything for the group that you're in. It's going to cut a lot of time for you. You can go to the next slide. One thing I've learned recently is try to use the EMR to help make friends with your consultants. So, and all the people who work in the hospital for you. So if you can make some dot phrases that help your hospital medicine doctors, your social workers, your PTOT, so they know what you're doing, try to make the medical record actually work for you. One thing you can do is just insert your logo on each top of each note so people know who you are and they can actually call you. There's a nice handoff function in Epic that you can use. I don't know if anybody remembers when we actually had paper lists and we put little check boxes and we actually wrote the 3 important things that mattered for the patient that day. You can do that electronically. If you haven't seen that in some of your EMRs, you can ask. And sometimes just making some quick dot phrases for notes that you write to help your consultants. What's the diet going to be? The dressing changes? Can you restart platelet medication? Can you do weight bearing? What's the actual disposition? That's all most people want to know, and try to cut out all the periphery that you don't really need. You can go to the next slide. So OBL and ASC was asked about. I think that's really too large of a scope for this session. The compliance issues are very different when you're in a OBL setting that maybe you own or you don't own, and you're trying to transfer data back and forth. So I think we could talk about that. If people had questions about it, I am in an ASC that's not connected to a hospital, and so if anybody has questions about that, we can kind of talk about that offline if you want to. And that's it. Thank you so much.
Wonderful. Thank you, Dr. Goodry. I think that was an excellent overview of some concrete kind of tips and tricks that people can use that sometimes, we're also guilty of maybe not taking advantage of some of the pluses that do exist in the EMR to make our lives a little easier. And I'm certainly guilty of that. And I seem to find a new button every week that I didn't know existed and, took maybe a minute or so off of my clicking around. Question for you, since I don't see any questions right now in the Q&A box. Any experience with utilization of scribes and using them to help with EMR documentation in the outpatient setting for you?
Yeah. Oh, I love that question. I love scribes. So I've had 5 scribes so far. All first 4 have gotten into medical school, and the 5th one is applying, not because of us, but it's a huge benefit to people who want to go to medical school and to the doctor. It's engaging. You're teaching them. They do much better in the first year of medical school because they know so much more. They can document everything. They know the medicines. It's really fantastic. And it also makes your life a whole lot easier. So I know that there's a lot of talk about virtual AI, and I think that is coming, but it's still pretty rusty out there. And I think maybe somebody's going to talk about that, but a scribe who comes in with you can be extremely effective and fast, and they can do the note right away while you're there. And that's going to cut your time. You still have to code and bill and check it. There's a very good amount of data about doctors are happier who have scribes in general for many, many reasons. So if anybody has any other questions about that, I'm happy to share it. You can find them through through like your local colleges. If you call the pre-med department and ask, is somebody looking, and gap years are a big deal. So we get each of our scribe through a gap year, and they spend a year with us. It's been a game changer for me, even though I am still very far behind on charts. I'm like the worst, but at least it's in there. And I can, if it's the weekend, I can do it on the weekend and the notes are actually done and the data is not getting lost. So I love scribes.
That's great. That's another kind of human touch to the EMR that we can use. And you're right. I think Dr. Beaulieu a little later is going to discuss that AI component that you were talking about, kind of to see what's down the pike. If there's no other questions, I think we're going to move to Dr. Craven. So thank you, Dr. Goodry. So our next presenter is my co-moderator, Dr. James Craven, president of Our Lady of the Lake Physician Group, one of Louisiana's largest medical groups with more than 500 practicing physicians serving Baton Rouge and the surrounding regions. Dr. Craven has been a practicing vascular surgeon since 2003, previously working in private practice in the New Orleans area, and then with CVT Surgical Center in Baton Rouge. As president at Our Lady of the Lake Physician Group, much of Dr. Craven's work revolves around working with providers on initiatives that further expand healthcare access and utilize technology to better serve patients. His presentation today will cover the barriers, challenges, and advantages of using EMR daily in the OBL setting. Take it away, Dr. Craven.
Yeah, thank you so much. So, just to clarify, the OBL setting I'll touch on a little bit, but I'll really focus most of the conversation tonight on how I view the technology piece as part of our larger provider network. In our Baton Rouge market, we are about 500 to 600 providers in our Baton Rouge market, but we're a health system, a faith-based health system that's across Louisiana, and we recently expanded into Mississippi. Totality, we probably have now 1,300 providers across both states. We recently onboarded our newest affiliate region, St. Dominic's in Jackson, Mississippi, into the Epic record. They were a historical Cerner shop. So our health systems journey with Epic probably began in 2012. We were a power chart acute care center across all of our markets. We knew that we were getting into value-based care with our clinical integrated network. We partnered with a large multi-specialty clinic here in the Baton Rouge market to get an ambulatory version of Epic in 2012. That was very successful. It continued to evolve until we knew that we wanted to merge our all of our acute care centers onto the Epic platform in 2017. A funny story, we brought up Judy Faulkner before. We all took a flight up to Verona, Wisconsin. If you haven't had an opportunity to visit, it's probably the closest thing I've ever been to, like Apple headquarters. It's just kind of like every building has a theme, and we sat in this large room, and we thought we were a big health system, but we're really not. And sitting right next to me is Judy Faulkner, and as she told her story of how she came along with the idea of Epic, which is really a database, a data warehouse for some ophthalmologists. Their initial loan to get the company started was $50,000. I think they paid that off in no time. And currently, I believe she probably has an estimated net worth of somewhere north of $7 billion. It's a fascinating story if you have the opportunity to read about it. But again, our journey with Epic is now, it is completely across our entire health system across both markets. Next slide. So to give you an idea of how a health system or a large provider network such, how do we see Epic as a tool? I see Epic as a strategic tool as I sit in my leadership position within the health system. All of our markets and service lines are on the same instance of Epic. We have no gaps as we've kind of brought our Mississippi colleagues on the same platform. So again, it's a great opportunity for us to review and mine the data for quality, scheduling, our revenue cycle. All of our charge capture is captured on Epic. And many of our larger markets have transfer centers where we can navigate patients across our health system with the tool, with the Epic technology. Another area that I kind of see the Epic tool or integrated EMR across the health system as a value is what we would call network integrity. And to me, network integrity is monitoring the flow of patients across our employed providers, potentially into the independent network, into the independent medical network, but making sure they stay connected to a facility of ours. And that's data that we can kind of pull from our Epic. And it's also very valuable when we do our value-based contracts with our payers. One of the newer items that we've kind of rolled out over the years that's become a lot more popular is Community Connect. So as London kind of pointed out, we historically, before I joined in this employed or leadership role, our historical practice was on paper. As late as 2018, when I kind of joined into a leadership role within the hospital. Currently, my historical group is part of this Epic Community Connect. And what that basically is, it's our instance of Epic that we are subsidizing for strategic partners. So one of those partners would be in our market, we have a large multi-specialty clinic, the Baton Rouge Clinic, which has about 100 providers, over 70 or 80 primary care physicians. We are an owner of what we call Premier Health. We have 27 urgent cares across the state of Louisiana. As late as later this year in November, all of those will be put on our Epic platform. So if you just look at this in a small market such as Baton Rouge, we may have 250,000 ER visits across both of our campuses, but we may have an additional 50 to 60,000 urgent care visits. Again, all of this being on Epic, where we can maintain network integrity of these patients that we serve. Some of the other initiatives from a health system perspective that we see value with the Epic tool is we will start subsidizing this to smaller facilities that don't have the size or scale to access Epic independently. So we have a signed contract with a hospital in Southwest Mississippi, where next year we will implement our instance of Epic and technology into that health system. There are probably 10 plus other hospitals and independent clinics that we are working with to expand our Epic, our instance of Epic to them. Again, it's a benefit to them. We can provide it to them at a much lower cost than they could get access to it on their own. Next slide. So this would be basically, we're an approved Epic Connect accredited health system. And basically what this is we provide this offering to individuals who may be participating with us on any of our value-based arrangements, or what we call our clinical integrated network. So if you really just take the math and say, look, I'm an independent practice of 3 or 4 providers. I'm currently on, you name it, med streaming, MMR, or whatever record it is, but you have that loss of connectivity to where you're doing your procedures. We offer an option of what we call Epic Connect. And basically what that is if you're part of some of our value-based arrangements, which is really no risk to you, you're still doing your independent contracting with the payers and so forth. But what we provide you is the Epic record at a significantly subsidized cost. It has evolved over time, because what you have to realize is a health system our size, if I was to offer this record in an unsubsidized fashion to a new provider, it would probably cost us somewhere between $15,000 to $20,000 on an annual basis. With this Epic Connect offering that we do with our strategic partners, is we offer it at a significant subsidy. So you have all the bells and whistles of what we offer for our own employed providers, but we offer it to you at a very subsidized rate, sometimes as low as about $3,000 a year for full access. Next slide. So one of our biggest initiatives as a health system is to be the #1 provider of choice in each of the markets we serve. To get there, we have to have what I would call a great experience for our providers that are employed. So this is kind of one of the ones, every upgrade to Epic provides me headache, whether my password has to get reset. But this is just a funny cartoon that I'd kind of shared in previous presentations. Just got an Epic update. This is the user manual for the EMR system. It is impossible for us to own this from A to Z, and it really takes a collaborative effort to kind of improve that patient experience, and to some degree, even for our support staff that help us so much in the clinics. Next slide. So this is one of the examples of a program that we put together within our health system. We call it the HOPE program. It's basically helping to optimize provider efficiency within the electronic medical record. So next slide. So what the intent of the HOPE program is we know, as everybody has already stated, the burden of the electronic medical record. I would agree with Mal, although if I send out a survey about what's given everybody the most angst in current state, I would tell you what I'd probably receive as top 3, in all honesty, right now, is the lack of ability to find labor. There'd be something with compensation, something with call, but it wouldn't be far down the list before we would bring up the challenges with the electronic medical record. So what we did in our organization is created this program, and basically its intent is to provide provider efficiency within the EMR. We're hoping, we talked a little bit about what some people refer to as all those additional hours that are spent in the Epic record, and you are right, Epic is monitoring all this information. I tend to refer to it as that pajama time, that time that clicks in somebody's record or somebody's user of how often they're using the EMR after hours. And we're really trying to devise a program around that to create some efficiencies and improve that experience, because we know, for us to be successful, it's all about retaining our providers, trying to make their breaking down those caregiving barriers that we all encounter every day. So again, what this is usually done is this is a physician-led program. We have many of our physician leaders across all of our markets that participate in this. We also have advanced practitioners who have become some of the best technology champions we have in the health system. And these individuals are able to come to the individual clinics where the providers are, sit with them. They can schedule an hour, a half hour. They can schedule as much time as they want. But again, it gives them that opportunity to kind of maximize the efficiency of their workflow and how they use the Epic record. We also have within our health leaders network, many of the physicians, especially our primary care colleagues, are all sharing dot phrases and referral patterns and so forth. Because again, the Epic record works if you're willing to invest the time in it to optimize it for you. So again, this is one of the examples that we've really kind of done to really help our providers out, utilize to prevent that burnout from the technology aspect of where we fund healthcare at. Next slide. This is another one. This is probably more focused. I can't say that I have many specialists. I may have some cardiologists that have utilized this, but again, to improve the patient experience across our health system, we're looking for those AI technology items that may improve how we manage our daily workflow. This is one of the most recent ones that we kind of rolled out to our health system. We piloted this in a smaller group. We've expanded it across all of our markets now, and it's been successful. What we're trying to figure out, it's this virtual scribe, and I think it provides the providers. There's many people that are playing in this space. Nuance is playing in this space. Suki is a virtual scribe option that, look, we figured out some sweet spots of where providers really can kind of find value in some of this technology. But again, we are always open to figuring out how can we ease the burden of the technology that we find ourselves so attached to. So again, that's kind of in summary how a health system really looks at the record. At the highest of levels, in the C-suite, they see it as very much as a strategic tool. At the provider level and looking at our provider network across both, as large as we are, we're looking at it from a physician experience aspect and how can we ease that burden? We know we are committed to this technology, but again, just a different view from independent practice to an employed model of how we view technology. And I think that's all I have.
That's great. Thank you very much, Dr. Craven. I think we're segueing into the next talk, Dr. Beaulieu's talk, because the AI component of this, I think, is something that kind of dovetails very nicely with his topic. And just kind of to add a quick question before I forget about it for Dr. Craven. Some industry folks I know have been involved in certain types of strategic ways to create referrals and to use kind of disease discovery type programs within Epic in order to help groups kind of find out who their, for instance, primary care providers are seeing, how many AAAs are they screening, are there missed opportunities for referrals? Have you all been utilizing any of that or seeing any of that recently?
So there is technology in one example, and there is some application. There's a couple companies that are playing in this, but there's one company called Ion or Aon, I believe is what it is. And it's basically, you know, to give an example that's non-vascular, it's overreading, it's technology that's reading. So we're a large health system. So every radiology report that is dictated within the chest or CT region of the chest, if there's any mention of a keyword that would suggest a pulmonary nodule, it's an immediate drop off into a work queue that our lung nodule team is basically working. And it's you know, let's be honest, as a surgeon, how many chest x-rays have we ordered preoperatively that maybe we really didn't see the report and we potentially could have missed? So there is that technology that even plays out into the vascular space. There's some that will overread any CT or chest, and anything that to do with aneurysm will drop that information, that MRN, into a work queue, and then you can have a navigator to ensure that that patient is appropriately cared for. So again, I think you'll see a lot of these play out. What I always look for is, what is the end? How many people are we really going to identify to invest that effort into it? I think in vascular, I'm still trying to understand, you know, how many AAAs would really come up. So we'll run pilot programs with it to say, okay, how many are we coming up with over this period of time? Do they have an already established diagnosis of an aneurysm, and is it worth the effort? We've had a lot of success in pulmonary nodules. We're also looking at it, some of our surgical oncologists, with pancreatic abnormalities. So again, I think we'll see this more and more often. But you and I both know how many times we looked at a CT scan that a radiologist has read for soft tissue, and there's aortic atherosclerosis up and down, and maybe they didn't even comment on it. So I think more to come in that, but I think that is where technology is really going to head, is mining the data that is already accessible to maximize a health system's opportunity to some degree. From a standpoint of monitoring traffic flow, we can run through, it's you know, I can understand where networking is going, but if I'm tied to someone's comp, I can't really act on that information. Does that make sense? So as a health system, we do have people, clinical informatics, who are constantly monitoring the traffic of flow in and out of our health system to, again, ensure that network integrity, because any large health system has tons of leakage. And in today's world where finances are relatively tough and challenging, that network integrity, or that keepage, as I would probably say, is some of the lowest hanging fruit that we can kind of capitalize on.
Excellent. Thanks. That was a very comprehensive answer and kind of puts a positive spin on all of the talk of kind of the personal effect that EMRs have, and it's kind of a 30,000 foot view from a health system. So thank you for that. And I'm now pleased to introduce Dr. Robert Beaulieu, who is a vascular surgeon in Ann Arbor, Michigan, and an assistant professor at University of Michigan Medical Center. Go Blue. Dr. Beaulieu is experienced in vascular disorders, aortic dissection, aneurysm, pediatric vascular surgery, and he will be discussing health information technology coding and the challenges and opportunities of integrating different EMRs Dr. Beaulieu, the screen is yours.
Oh, fantastic. Well, first of all, thanks for giving me the opportunity to present this. I am up at the University of Michigan, and a lot of credit should go to Jenny Ann Yee at Colorado for actually designing this talk. She really deserves even more credit for her work on the Health Information Technology Committee for advocating for improving the physician experience in the EHR. And so I think she helped to prepare this slide deck, and I'm giving this in her stead because she couldn't be here, and I hope I do her justice on this. But I'm actually starting to think, seeing this panelist list, that I was really only invited to talk because my name looks like I'm a person from Louisiana. But most importantly, I hope that this presentation can offer both a look at some of the challenges, but as well as some of the opportunities that we have to really take back the EMR. And so it starts with the fax machine, which is somehow the workhorse of any 1980s trading firm or any 2020 medical office. And without the HR, the pipeline for consolidating medical information looks something like this. A fax comes in on this really great machine. There's a group of excited and energetic office assistants to help to put that in a large pile, which later that day, or maybe later that year, that pile gets converted into some sort of electronic medical record. And you get to sit and from somewhere and view that whenever is most inconvenient for you. And so using the EHR is not just meant to provide an existential threat to fax machines. It's also used to integrate and store this data and then access it in real time. And the information, we largely think of text-based informational aspects, but it can come from anywhere. It can be sound files. There are multiple novel techniques for inputting image files now, all of which should be seamlessly integrated with the EHR. And you'll have to excuse, some of this talk is a where we should be rather than where we are, and I totally understand that. I think we've gotten a pretty good look of where we are and maybe some of those pitfalls, but I'd really like to talk about where we could be. I think one of the really awesome parts on this is that it can also be viewed across multiple streams, but it all relies on the data that go in there. So it's not surprising with those goals that there's been relatively a golden age of EHR. And so there's been improved adoption across the majority of healthcare providers. This is allowed for enabling rapid technological advances such as telemedicine and digital health. I mean, these were essential for allowing us to pivot our method of providing care during the pandemic. Further, this utilization has increased our data that we can use to create smart EHRs, that we can allow machine learning and AI algorithms to really incorporate the possibility for personalized medicine while reducing the reliance on the physician to have to review every form. However, it's come with a cost. And I think one of the big costs that we've talked about has been an increased provider burnout. There's an increased reliance on the administrative data for costs, and especially for how we bill patients rather than how we provide care. And the expansion of the EHR system has led to poor interoperability. And this really requires someone who is fluent in over 6 million forms of communication to master. Some of these frustrations really arise because of the basic premise of data science, and that's that if you put garbage into a computer, no matter how nice it is, you're going to get garbage out, and it may look a little nicer. But and so while we create these systems and tools that are meant to take advantage of this greater data accessibility, one of the biggest weaknesses in this paradigm is the reliance on this data, and really data that comes from multiple sources and with multiple formats. And so it's not really surprising when you see all of the different systems that we're trying to consolidate data across and the different ways that data are stored in each of those systems and how it's accessed, that it's difficult for these systems to communicate. And the way that data is put into one system influences how it's viewed in another. And I think some of this happens because all this data are meant to serve very different purposes across these systems. Not only do we need it for our own uses of patient care, which should arguably be the most important reason for this, but it needs to be accessible to patients themselves and transparent for use within our internal algorithms. And it needs to work within our EHR systems. And now there's an increasing need for that data to be reportable due to reliance on EHR for reimbursement and quality reporting and public health data. And as we shift more towards value-based performance plans, yet the manner into which each EMR integrates patient data into the record to achieve these goals creates its own challenge, let alone talking amongst the systems. So those are some of the 30,000-foot challenges that we face with increased EHR use, but it's important to remember that this whole system is just a tool that we have actually created. And I use we in the sense of the healthcare community, not necessarily vascular surgeons or surgeons at large. And like any tool, it should conform to the need of its users. And in this sense, I really do think its users are vascular surgeons and surgeons at large. And so in that sense, we have to let this tool, conform to our need. I mean, we are adept at creatively and effectively employing the tools that we have at our disposal on a daily basis. I mean, even just look in the OR. And so we really have a pivotal role in helping to influence this tool and the integration of EMR systems, lest we let Epic become self-aware. And so what we can do to improve our experience, and as you can see in this graphic from the AMA's training the EHR or taming the EHR playbook, at the user level, we are really relegated to the box up in the top left corner. But within this arena, there are some very important opportunities for us as users, and even from the societal level, to help influence our experience. Through the creation of tools or shared resources of documentation templates, for instance, smart text phrases or other shortcuts in the EHR notes, the society really has the opportunity to help members improve EHR utility for them, especially for vascular surgeons. As many that have used these kind of tests, a standardized note template can dramatically increase efficiency and reduce unnecessary time inputting data, especially into clinical encounter documentation. This can automatically draw in information that allows you to accurately capture codes, diagnoses, and findings to help make data more transferable to other providers and institutions. And this uniform reporting makes it easier for patients to understand by using a common language. This is especially salient in the era of open notes, in which all documentation should be considered with the patient in mind as they will be able to view it. Also, using templated forms for data extraction, such as the VQI, but reporting metrics for value-based performance programs as well. These all serve as achievable short-term goals through a consolidated effort to provide society members with standardized EHR reports. And the power that the society really has is to use the fact that our members are operating over multiple EHRs to help make standardized reports that work across these multiple EHRs. But we're not alone in our pursuit of helping to shape the EHR. In fact, we can use a lot of team members that we use on our daily basis, but also as tools to help us really shape our EHR experience. Specifically, we can use the EHR to leverage who inputs certain types of information. We can empower the patient to aid in their own documentation, such as their medication reconciliation or filling out pre-visit questionnaires through the patient portals. And this has the potential to decrease our garbage in risk that I was talking about earlier, especially as we try to click through so many boxes with an ever-increasing number of encounters. Further, this reduces the risk that crosstalk between systems do not carry over appropriately, especially if we can standardize a patient portal in which the patient can input that data and then it can be incorporated into multiple systems. This also opens the door for patients to report novel outcome measures directly to the provider in a way that does not utilize a clinic visit or rely solely on provider-based documentation. And this is especially important as we start considering our patient-driven outcomes as a measure of our success in providing care. So as many of these tools can be built in organically to the EHR, many of these tools can be built in organically to the EHR interface, and generating standardized templates that are compatible across multiple platforms, actually useful patient questionnaires and a meaningful way for them to input them, as well as a meaningful way for us to communicate with patients where they are all the low-hanging fruit that we can help organize as surgeons. Because nothing is worse than being auto-enrolled in a 9-hour in-person training module to help learn how to use a computer system that bills itself as intuitive and efficient. I think our power in the society is to build something that allows this system to work for us across these different platforms. So I think this leads itself to a couple conclusions. It's an integral part, but it must be optimized. It doesn't come standard out of the box. Who optimizes it is a point of ongoing debate. I think we have a role as individual users, but our collective power will probably allow for a better optimization. And I think one of the easier optimization strategies is standardization, namely allowing for forms and the dot phrases like the .vas exam phrase that was mentioned earlier that just make it easier, but you don't have to do all the work to put in and create those. But we must be involved throughout the process. We can't let this just be a tool that the EHR data is used for billing, and that's the important point of it. So I again would like to thank the society and certainly thank Jenny Ann for her slides and the ability to participate today, and welcome any questions.
Thanks, Dr. Beaulieu. I know I could have swore you were from Thibodeau, so I appreciate you you giving a shout out to us poor Louisiana people. It was either Thibodeau or Chack Bay. I wasn't sure, but thank you. You know, I do think we're over the hour, but we do want to open it up. Keith and I want to open it up for Q&A. If anybody has any questions, or open it up to our panelists tonight if there's any specific questions that we may be able to answer for anyone.
I think there's a question in the chat from Dr. Molnar, he asked about the fact that large healthcare systems have a single EMR that can be optimized. Many community practice surgeons have to deal with multiple EMRs. He says, I work with 3 hospital systems, each using a different EMR, and our office has a 4th EMR, all hospitals within 15 miles of each other. No interaction between systems, any foreseen options for getting systems to interact, communicate.
I do think, look, I thought Mal brought it up well. The HITECH Act was great. It funneled billions of dollars out there, but it really missed the mark, right? I mean, we literally funded companies that are no longer even in existence, or they're not even relevant in today's state. I do think, you know, I do think it will be large health systems that probably share EMRs. You know, we're a community of, I don't know, 400,000 in the greater metropolitan area. You know, at some point we may have 1, 2, potentially 3 different instances of Epic in our own city, which is really kind of silly, and I don't think that does the patient any favors, right? Because they're all variations one of themselves. I do find, as a health system, I do think Epic has become a recruiting tool. A lot of these trainees like staying with similar technology, and we do find that that's something that kind of interests them. I know there was a comment earlier about OBLs, and I just wanted to share that with, you know, whether you're in an ASC or an OBL, if you're a for-profit and you're working on a P&L, no one's going to invest in high-end technology for that, if that makes sense. You know, I mean, you're going to be peeling revenue out. You'll never be able to subsidize a record, I would think, like an Epic, unless it's truly a health system ASC that they have majority interest in. Otherwise, anything that the physicians are majority owners in, I think would really be a struggle to get a high-end electronic medical record in there.
That's a great answer. We have 2 more questions that came up. One was a very practical one from Dr. Webb, who asks, where can we find smart set templates for vascular surgery for Epic EMR? Anyone want to tackle that?
You can go into Epic World and join in. And so Dr. Burgess, did you have the link on your presentation by any chance on how to access those smart phrases?
I do not, but I can provide that afterwards, if that will be helpful. Do you have a mechanism to do that for people, or?
You probably could just put it out.
Post it on SVS Connect, you know, as a follow-up.
Yeah. And I think that's a great takeaway and a great question, Kent, just that maybe that's something the community practice division can kind of focus on, because I do think, you know, we're all reinventing the same wheel. And you look, there may be super users in Cerner and super users in Epic, but some repository where we could kind of pull this data from. I thought some of those physical exam templates that you showed, Dan, were great. And I think, you know, how do we tap into that? I think it's in there. I just don't think we're investing our time to communicate across geographies to kind of share some of these opportunities there.
We have to make sure it works across all systems. So, you know, that Epic committee is great, but the people who are writing the codes are excellent. They're 2 vascular surgeons who have a background in coding and have built a lot of these forms, which has been pretty amazing. But at first you couldn't share it between, you know, if you had this version of Epic and that version of Epic, and that's what everybody complained about. So the new work that's being done is going to be able to share it across to all of your versions. So that's what Epic didn't understand about what we were doing. So I think that's going to be very, very helpful. And we tried to build it streamlined. And so I will say a positive about Epic for that. They are understanding a little bit more specialty. My concern is that the more that we build all of this, the more they want us to do. So yeah, that's great. We're building in VQI, but now you're filling out the form for it. Your op note's it's gonna have to have every data point, and it's gonna be time consuming. So the more we do and the more facile we get, the more work you're gonna do, I can promise you. And the more people are gonna ask of you. So maybe I would love for Mal to talk about on the opposite side of how we're trying to, sorry, Mal, how we're trying to have the government ask less of us in data, because all we do, you know, I got asked the other day, no, you have to write who gave you the information or you can't bill this level. You know, you have to say that the patient gave part of the information, but the spouse gave part. I'm like, who cares? Like, I'm putting the data in. And so I got kicked down a level because now, you know, well, my coder says you can't bill this. So in reality, where we sit as physicians, we're like, this is great.
Yeah.
But that's not really the reality. And I'm sorry, that was negative. Kicking it to
There
you,
is
Mal.
actually, there is one positive in that I'm sure 99% of people already know, is that the documentation requirements for level of E&M coding has changed, and it's much easier now
It is.
to kind of figure out how to do our coding. And actually our coding levels kind of bump up because of the nature of what we do, generally more complex conditions. So most of my clinic visits are now a level 4, where they were kind of a level 2, 3 before, because I just didn't do that much documentation. But now, just by the complexity of the disease and the nature of what we do, it's much better. So that everybody needs to take advantage of, because you know it's a zero-sum game, and that money that went to the E&M came from procedures. So you have to kind of capture that, or it's going to be a net loss for you.
I just want to interject. Thank you for making that point about the slippery slope to always doing more. And from the VQI side, I'm not sure we've answered that. You know, what is the great incentive for the physician who's doing that, you know, data entry? You know, in my just local experience, you know, with some of these things, no one really listens to you say, I'm just not going to do it. End of story. You know, I think sometimes it honestly it comes to that, but it's very hard to be disagreeable like that and push back as a sole person. But I'm afraid sometimes that becomes the only answer. Sorry to be negative, but that's you got to stand your ground sometimes.
I'll maybe end on a slightly more positive note. I think that you know, our interpretation right now of how data make it into the EHR is all through manual input. And I don't think that's actually going to be the reality for how the Epic system or any systems progress beyond, you know, it's hard to give a timeline for this, but it is not hard to imagine a system that knows what data to input in the variable of what stent you used, because it goes into your billing record and sees what stent the nurse input in the chart. Or it doesn't, you know, it's not hard to imagine utilizing some of the other areas of Epic besides literally the documentation element where you click buttons through it to answer some of these questions in real time without you having to do it. Now, it's hard to see it in its current iteration because in a lot of ways we're cheap labor that is willing to do it because it's a requirement. But when we take away maybe the government's ask of it to get a certain level of billing, we just look maybe through pure altruistic purposes and making sure the VQI is as up to date as it can be, making sure we have the data captured for our patients. It's not hard to see where a system that maybe incorporates the information from other sources besides just me or you would be a really powerful thing. And maybe that's what we should be advocating for rather than just an easier way for us to input it.
It's a great point, for sure. I think that's ultimately the way to go. Have the other pieces of Epic work into the documentation. I just have a quick question for all of our panelists. Thus far, we've been talking a lot about how we use the EMR. You know, the biggest change we've seen in the last, I would say, year, and even in the last 6 months, is all of our patient notes and documentation are immediately available for our patients. So they get the ding on their phone for their EKG, their CAT scan result, even before I've had a chance to even look at the pictures. And they're already messaging us in the portal, through PowerChart, through Epic, whatever health system, to kind of find out, why do I have this incidental finding and what am I supposed to do about it? How do you all see this kind of immediate mirror image access that the patient has to their medical record and each of our notes impacting us? Because I really think that's going to be the much bigger issue coming down the pike. And it's already here, really. It's increased the amount of traffic on our portal and phone calls and so on and so forth. So just a quick maybe question, if any of you have had recent experiences with that, I'm curious.
Yeah, it's gonna be more work. So your inbox, if you're on Epic, every time there's a new iteration, there are more boxes and the results duplicate, and you've got to check them. I'm not sure what's going to happen, but patients have become, at least in what I'm seeing, much more impatient. I want a doctor to call me back now. I need my results now, which is not always great for the patient. From a cancer perspective, it's been a disaster for a lot of places. I think more mid-levels we're going to add in more layers, which is not the right answer, I don't think, but I think some people are doing that. Their mid-level handles their inbox and calls back a lot. I think we're having to do more visits. Yeah, it's more work. And there are some people who are getting restrictions, like you have to answer it back within an X amount of time, which is really putting a lot of constraints on physicians. So, more work.
Anyone else with any comments? If not, hopefully we can reconvene and continue this discussion. I think all of this is going to be available and recorded and in podcast format as well. So any of these links and email addresses and such will be available. And certainly the information that was asked about we can provide in SVS Connect. So this has been a great session and great discussion. I'd like to thank my co-moderator and all of our presenters for sharing their knowledge with us tonight and spending the time. I'd also like to thank the SVS Community Practice Section, the Health Information Technology Committee, and the Wellness Committee for their collaborative efforts to put together this webinar about making the EMR work for you. I'd like to invite everyone to join the community practice session by emailing us at the address you see on the screen. It's the svscps@vascularsociety.org. The SVS CPS membership is available to all SVS members in good standing who are interested in serving patients in the community practice setting. Hospital and practice administrators are also welcome to join as affiliate members. So thanks again, everyone, for your participation, and have a wonderful evening. Bye-bye.